So as we round off Chapter 5, Clinical Management of Impairments in Action, now we're going to look at cerebellar and basal ganglia impairments. So what would happen? Well, coordination. What would happen in coordination? Observe patients performing functional movements and noting characteristics of movements used. Like ask them to do a finger to nose, ask them to do heel to shin. And like that video that I showed you of John, he has very difficult time getting the finger to nose with accuracy, getting the heel to shin with accuracy. You and I would take this for granted, but it's a very simple task, but it's difficult to do if you have a cerebellar ataxia. So the treatment for that would be to repeat and practice of functional task-specific movements. We would do weight-bearing activities, we would do figure eights, pick up a water cup, empty cup, different scenarios. So here's some other coordination tests, non-equilibrium, which means that they would not be testing your balance, but there's some coordination tests. Finger to nose, finger to therapist, finger to finger, alternate nose to finger, finger opposition, mass grip, pronation, supination, also known as dysdiakinesia. Can they do that 10 times? Rebound test of the Holmes, tapping, drawing a circle with the hand and the foot, and fixation position, holding upper and lower limb. So now the other thing that you would be looking for is involuntary movements such as tremors. Tremors are identified through systematic clinical observation describing body parts affected and conditions under which tremor is activated. The treatment strategies to compensate for movement rather than changing the movement itself. So don't try as hard with movement. Decrease compensation of other muscles. Weight-bearing activity of hands is actually very good for tremors. So doing weight shifting, quadruped, or just having them put both hands on the table and shifting back and forth, some kind of weight-bearing activity is very good. Now, somatosensory impairments results from sensory testing interpreted in relationship to established norms or in comparison to uninvolved areas. So what's the relationship between sensory loss and function? Unfortunately, is not clear, meaning if they have sensory loss, does that automatically mean that they lose function? Not necessarily. So it's not entirely clear what the true relationship is. Now, what's a summary of methods for testing somatosensation? So there's quite a few of them. And let's take a look at these, because this would be something that you could definitely do in the clinic. So for discriminative touch, so how would we test touch awareness? Well, you could, the stimuli could be light touch to the skin with a cotton ball. How would they respond? Well, they could say with vision included, patient says yes, or signals when the stimulus is felt. And then you can score that on percent of correct responses out of 5. So they get 50% correct or not. So you need some kind of way to objectively measure them. You can do touch localization, so lightly touch skin with cotton ball or a monofilament number. With vision included, patient points to the location of the touch and record error in accuracy or location. You could do bilateral touch, such as sensory extinction. Touch the patient on one versus both sides of the body with fingertips. With vision included, patient says 1 or 2 to indicate number of stimuli. So do they have 2-point discrimination? Record presence of sensory extinction. You could do touch pressure threshold. Use range from the Symes-Weinstein monofilaments. With vision included, patient indicates when he or she feels the stimulus. Score the number of the thinnest filament felt. Normal is perception filament, which is 2.83. So all these filaments will have a number on them. And if they can feel the perception filament of 2.83, then you can mark that. Or you can mark which one they do feel and note that. But that's a good objective measurement. Again, 2-point discrimination using 2 paper clips. Apply the 2 points to the skin. Maybe start with 5 meters apart, then gradually bring the points together. Patient responds that they feel 1, 2, or they can't tell. Now, diabetics would have a hard time with this as well. How would you test proprioception? Well, you could do vibration by applying a tuning fork or vibrometer to the skin. Patient indicates when he or she feels stimulus. Percentage of correct would be your objective and how you would document that. Joint position, so you can basically move their joint, let's say their shoulder into flexion with their eyes closed and say, well, how much degrees, or how do you think it is, or put it back down and then have them repeat it and see if they can bring it back to the same position at the contralateral limb. Now, joint motion, passively move the joint into flexion or extension. Patient reports whether the joint is bending or straightening, so joint motion. And then stereognosis is place a series of small objects in the patient's hand. Patient names the object, may be able to manipulate object first. So you put a marble in, put a tack, anything, and see if they can tell what it is. Last one was pain. You can easily just have them subjectively report pain. You don't never want to give them pain. Visual impairments, there's visual testing, visual acuity, depth perception, visual fields, and the oculomotor control. You can do vestibular impairments, examination, test of gaze stabilization, posture and balance control, dizziness. We can do treatment, depends on the underlying cause. Is it BPPV? You can do the Dix-Hallpike position, which I showed you the videos for. The links are in the classroom module. And then the vestibular rehab, you would do exercises to treat symptoms of dizziness and balance. So there are real specific exercises. And when it comes to the BPPV, it depends on which crystal it is and what positive they get. So if they get the eye fluctuations and nystagmus, which are vertical versus horizontal versus circular, you can tell which semicircular canal is affected. Patients can also have spatial deficits, such as hemi-neglect. And how would you know that? Is if they come in with half of their face is shaved, they only eat half of their food on the plate because they can't see the other half, or they walk into objects because they can only see one side of the wall. So that would be some subjective complaint that maybe the spouse tells you. Assessment, formal standardized testing or observation of patient performing functional tasks. So how would you do the treatment for that if somebody does have spatial deficits? Well, you do visual scanning therapy, you can do sensory stimulation to increase awareness, modifying environment to accommodate the impairment. Now, non-spatial deficits, just cognitive. This cognitively, and usually the easiest scale or the standard scale is the Rancho Los Amigos scale. Alertness, basic arousal process, allowing patient to respond to stimuli. There's 8 levels. Level 1 would be no response, needs total assistance. Level 2 would be generalized response, needs total assistance. Level 3 is localized response, needs total assistance. Level 4, Rancho, would mean they're confused, agitated response, needs max assistance. So you need to be really careful with level 4 and level 5 patients. They still need max assistance, but they can be easily agitated. They can have an inappropriate response. Levels 6, 7, and 8, they're still confused, but they usually have an appropriate response. They need moderate assistance. Level 7s and 8 are minimal assistance or standby assistance, and they're more appropriate. So depending on what level they've been diagnosed as, the ones you really have to be careful are 4 and 5, because they're confused, they could be agitated, and they need max assistance. Attention deficits, profound impact on sensory, perceptual, and motor functions. How's their attention? Are they focused? Do they have sustained attention? Do they just have selective attention? Where most men, when they're watching a Laker game, they only have selective attention, right? And do they have alternating attention, or do they have divided attention? So these are some things that would obviously play a role in the ability for them to rehab. Okay. Again, we've talked a little bit about memory for implicit versus explicit, short-term versus long-term. Do they have the ability to process, store, and retrieve information? How would you need to obviously assess short-term memory and long-term memory? So one thing you could do is ask the patient to remember 4 words, pepperoni, mushrooms, bell pepper, and onions. Toppings on a pizza, right? Then test immediate recall. Then test it after 5, 10, or 30 minutes and see, or pick something that they like. If they like sports, pick 4 sports teams, whatever the case may be. Okay. Again, to review, implicit is unconscious memory, so repetition of movement to promote learning, so repeat, repeat, repeat. Explicit is conscious, so you would need instructions on how to perform a task. Okay, so those are ways to train or learn unconsciously or consciously. Obviously, we want to do a combination of both. The impact of explicit instruction on implicit learning depends on your type, your timing, your meaningfulness of instructions, as well as the location of the central nervous system, meaning sometimes it could be detrimental for CVA or basal ganglia CVA if you're giving them too much verbal cues or tactile cues, whereas it might be beneficial for a cerebellar CVA. So it really depends on how much instruction you want to give them or how much you want them to be able to repeat on their own. Okay? And when we do treatments, we'll obviously explore this a little bit better. Today I'm just introducing that there is a difference, meaning how I would structure my rehab based on where the injury is. I wouldn't do the same cookie cutter recipe for everybody, because if they have a CVA versus a basal ganglia CVA versus a cerebellar CVA, those are 3 different locations and they will respond to different types of motor learning. So being aware that that does play a role, and how would you find if they had a CVA, a basal ganglia CVA, or a cerebellar CVA, you would look in their medical chart. All right, so again, the take-home message is there, depending on where the location is, we need to curtail and make everything specific to that patient, and nothing is standard when it comes to neurological rehab. All right.